Hello, and welcome to today's session, the second of a two-part series on shared decision making, the journey with gene therapy. I'm Dr. Courtney Thornburg. I'm the medical director of the Hemophilia and Thrombosis Treatment Center at Rady Children's Hospital, San Diego. And I'm joined today by Brian O'Mahony, who is Chief Executive of the Irish Hemophilia Society and former president of both the World Federation of Hemophilia and European Hemophilia Consortium. This education is supported by independent educational grants from BioMarin, CSL Behring, Pfizer, and Spark Therapeutics. Before we get started, I would like to mention that your questions are encouraged. If you have questions for us, please make sure you type them in the chat or comment box so we may address them during today's session. And so, just as a recap from the first session, we focused on the journey to gene therapy. We talked about education and shared decision making, as well as eligibility and administration. And today, we're going to focus more on the post gene therapy journey. And so, Brian, thanks for being here with me today.
Hi, Courtney.
Yeah,
Good to
you
see
had a
you.
great, nice to see you.
Yeah, so I think in the post gene therapy environment, the first thing patients will often ask about is about restrictions on their lifestyle post gene therapy, and there are some restrictions. Certainly, the person with hemophilia who's had gene therapy needs to refrain from any alcohol use at least for the first year, and a moderate intake of alcohol after that, because obviously gene therapy is targeted to the liver. Alcohol impacts the liver, and you don't want any undue stress on the liver. And frankly, if somebody was to drink during gene therapy, certainly in the first several months, and they get a rise in their liver enzymes, that could be mistaken for, transaminitis due to gene therapy, and perhaps unnecessarily cause the need for steroids. There are also restrictions on exercise in the sense that sometimes with gene therapy, there might be post gene therapy, there might be a temptation to start doing extreme exercise. And of course, extreme exercise can also raise your liver enzymes. So I think, like any new therapy, if somebody is going to change their exercise pattern, they need to pick a new sport or activity carefully, and they need proper training and proper equipment for that. And I think it's also worth mentioning that depending on the factor expression that they have achieved, that they may still require um, uh, supplemental factor concentrate for surgeries, or maybe for major traumatic bleeds, or for some medical procedures.
Yeah. Those are great points, and I think particularly as you point out, potential impact of sort of high intensity exercise on the liver and the liver numbers. The other things patients should be aware of in regards to liver health would be avoiding other hepatotoxic medications, Tylenol in excess. Typically we try to avoid nonsteroidals in hemophilia, but then post gene therapy we might have to think about other medications to be careful with, as well as herbal supplements, and to make sure that people are discussing anything they're taking with their treatment team. And then the other thing is, I think we're talking about exercise, but actually exercise, to in a controlled way could be good in terms of overall health and avoiding obesity and fatty liver, as fatty liver could be another reason for sort of elevated liver enzymes.
That's true, and also that the individual who's had gene therapy has to use barrier contraception for the first 6 months, because the vector is shed in all body fluids, including semen, and also because the potential impact on a fetus is just unknown. There's no work done on that. Female partners of people with hemophilia who've had gene therapy should avoid pregnancy for at least 6 months after the gene therapy dosing. And obviously, people with hemophilia may not donate semen for 6 months after treatment, and they're also ineligible to donate blood, tissue, cells, and organs. Although, frankly, that's not a big change from the past. They've never really been eligible to donate blood or other tissues.
Yeah. And I think that we're talking more on the the post infusion restrictions, but going back to our discussion, uh, um, in the first session, these are all very important considerations for people who are considering whether or not to pursue gene therapy. Because certainly, if they're not willing to restrict alcohol, or if they're in the period of life where they're trying to do certain exercise, or have a family, then they may need to take that into account. Because um, again, you wouldn't want to go through gene therapy and not be able to adhere to the restrictions, or have sort of negative impact on um, you know the well-being that you're looking for, or mental health.
To be fair, these are not surprises. They should
Yeah.
not come as surprises to the person with hemophilia. It's not like they get gene therapy and then afterwards they're told, "Oh, by the way, you can't
Yeah.
use alcohol free, or you have to use bioconception." These are part of the shared decision making process. They're part of the informed consent process. So I think it's these are not surprises, and certainly we. I was in a big meeting last year, and we surveyed a lot of people, and nobody really had a concern about these. They
Yeah.
thought these were realistic and reasonable restrictions, and that would not have stopped people having access to gene therapy for the vast majority of people. And I think you mentioned mental health, and I think that's interesting as well, because one of the core outcomes of gene therapy is defined as looking at mental health, and of course you need a baseline for that, maybe using something like the Core mental health tool, and there are potentially positive and negative mental health implications. I mean, in terms of positive, you could start developing what Cedric Harmon's in his paper called a hemophilia-free mind. I'm not sure your mind will be or should be totally free of hemophilia, but you may be able to be more spontaneous, because if you've got a significant factor expression and you can stop prophylaxis. You don't need to think about, okay, I'm taking a long haul flight, or I'm going to the gym tomorrow, or I'd better do that on my prophy day. So to give spontaneity can enter into your life, whereas up to that point in life, as a person with hemophilia, you often have to think about, oh, if I'm going to do this, I better take treatment beforehand. So I think there are a lot of potential positives from a mental health perspective.
Yeah.
In terms of negatives, some people talked about potential loss of identity. Um, but again, I think that can be overstated. I think sometimes people remove themselves from their hemophilia community if they've had gene therapy, which is not necessary. And of course, you still have hemophilia genetically. If a man with hemophilia has a daughter after getting gene therapy, his daughter will still be a carrier. Um, and perhaps one of the other negatives is that maybe people realize that that there could be problems in your life that you attribute to hemophilia, and then you get gene therapy and you got a significant factor expression, and you realize the problem is still there. This was not caused by my hemophilia, so there could be an adjustment period there as well.
Yeah. No, all great points. And so I think as people, think about these restrictions that are required, they need to put it in balance in terms of, as you said, potential for, hemophilia free mind, decreased treatment burden, but then, the other aspects that you just mentioned. I think the other, very important thing in terms of at the time of infusion and then post infusion that we need to talk about is managing, adverse events, and being on the lookout for them. And so, the first step, during the infusion, infusion related side effects, allergic reactions have been reported in some studies, including symptoms like vomiting, fever, and myalgias. They can be treated, with anti-inflammatory and allergy medications and slower rate of infusion. And it's anticipated that, even despite infusion reactions, you'll be able to complete the infusion unless it was a, very, very severe reaction.
I agree, and I think, and you should try and do everything possible to complete the infusion, because this is the person's one chance to get gene therapy, and if you don't complete the infusion, they won't be able to redose with gene therapy, and
Yeah.
that's their one chance gone. So, as you say, if there was a reaction, slow it down. Use medicine, use meds to damp down the reaction. But I certainly think if somebody's getting a reaction, you just deal
Yeah.
with that as part of the process.
Yeah, and I think that's part of the hemophilia treatment site preparedness, and is having those procedures in place, so to know what to expect, and then immediately to know what to do. So yeah, so it's not um, stopped completely, because as you said, that would be devastating. And similar, making sure to have very good IV access,
Yes.
so that you can avoid any interruption in the
Yeah, I
treatment.
certainly think in the gene therapy infusion, they typically set up two IV lines, one for the gene therapy and another one just in case something else is required, and
Yeah,
that's sensible.
yeah, definitely. The other thing, in terms of um, you know what we're looking for in terms of efficacy is increase in the factor 8 or factor 9 levels. However, in particularly with factor 8, there have been some reports of sort of supraphysiologic or high factor 8 levels. And so the treatment team and patients need to be attuned to that. And depending on the situation, there might even be indication for short-term anticoagulation if there's very high factor levels and other risk factors for thrombosis.
That's agreed. And I think there have also been a couple of similar reports in some of the factor nine clinical trials. They tended to be, temporary, and the levels tend to come back down. But you're right. I mean, it's we there's no way of knowing, of predicting what factor expression any individual will get. They may get no increase or a small increase. They may get a significant increase, bringing them in close to or into the normal level, or they may in fact get super normal levels, and hopefully that happens. It come back down, but there's no way of predicting.
Yeah. Yeah, and I think, for hemophilia education, we particularly focus on, what bleeds look like, especially muscle bleeds and joint bleeds, and in the right, context, if there are very high factor levels, then educating patients on what to look for in terms of thrombosis would be important. And actually, the symptoms can be quite similar in terms of swelling and heat and pain. And this isn't something that we're expecting with the majority of patients, but it's still something, particularly in early phases, that people need to be on the lookout for.
Agreed. Agreed.
And then we started in talking about the great importance of the liver health, since the effect of the gene therapy depends on the liver for the factor expression. And very important part of the post infusion monitoring is monitoring for liver inflammation with liver enzymes, particularly ALT. And it was really important to recognize this early, because in order to prevent loss of factor expression, then that needs to be treated emergently or immediately with immunosuppressive therapy.
I agree, and I think in a sense it's not surprising that you see a quite a significant amount of transaminitis, because you're sending in trillions of viral vector genomes to the liver, and the liver quite understandably in many cases reacts with a little bit of inflammation. And it's quite interesting, when you hear a hepatologist talking about this in gene therapy, they kind of you're seeing small increases in liver enzymes, which would not worry them from a liver disease point of view. I think one hepatologist memorably said you wouldn't get out of bed for the kind of ALT increases you're seeing. But I think that so it's not really the concern. Really doesn't seem to be this is causing liver inflammation, which might damage your liver. It's more
Right.
that even that small degree of liver inflammation, if it's missed, could lead to a loss of factor expression. So the liver cells could actually you could lose the liver cells that are expressing the factor. So you've destroyed the efficacy of the entire procedure. So I think it's absolutely crucial. In the early stages of follow up, and people with hemophilia might wonder, why do I have to have liver function tests done so regularly in the first 3 months post gene therapy? It's for that reason. You don't want to miss any even small increase in liver enzymes, which might mean that if it's missed, that you lose your factor expression.
Yeah. Yeah, so I think it's important discussions up front before gene therapy, and especially afterwards, in terms of you know the patients knowing why this is important, and really having strategies in place for adherence to the liver test monitoring. And
Absolutely,
then,
because
yeah,
if somebody drinks a lot of alcohol and their liver enzymes go up, the center doesn't know if that's due to alcohol use or if that's due to transaminitis due to the gene therapy vector. Do you start steroids? Do you not start steroids? So you don't need that kind of confusion.
right. Yeah, and so in terms of talking about the immunosuppressive, yeah, the most common treatment is corticosteroids, and uh, those may be prescribed for weeks to even months, sort of depending on um, the individual response. And it's important to be aware with that then you need to monitor for adverse effects of the steroids. So,
Yeah.
which can be sleep disturbance, mood disturbance, increased appetite, all of which can have significant, impact on sort of well-being, as well as other more, sort of health effects in terms of blood sugars or blood pressures. So that will have to be part of the, um, management of the steroid therapy.
No, I agree. I mean, people may have used steroids in the past for a week if they had a bronchial infection or something, but this here you're talking maybe an average of up to 7 months with factor eight and up to 3 months if they're required with factor nine. So it's a significant amount of time to be on steroids, if and when they're required, and that needs careful management. And also, I think this is a crucial example of where you need very good communication between the centers, because if you have one center doing the gene therapy, if you have another center monitoring the liver enzymes regularly, then you want to make sure it doesn't slip between the cracks. That
Yeah.
if there's an increase, that is notified quickly to the patient, and he can get steroids very very quickly.
Yeah. Yeah, and I mean, it's an important point that there's going to be different models of care of gene therapy in terms of some centers that will sort of offer one stop, shopping. Where they'll do the education, the enrollment, the infusion, the follow up, and then other times where there'll be the infusion center that's separate from the home center. So having the sort of the roles of each center and fail safe communication is going to be critical.
I agree.
And yeah, I think both for certainly for the short term monitoring that we've been talking about, and then also for long term monitoring. So as even before the infusion, but and certainly after the infusion, there needs to be detailed planning between the healthcare team and the patient in terms of the follow up plan for the initial, very frequent follow up, and then going out to monthly and then yearly follow up.
I agree, and I think there's been a lot of debate and discussion in the community over the last couple of years about how long the follow up should be. Should it be, and the regulators will require 5 years follow up, or in some cases 15 years follow up. But realistically, it should be lifelong follow up. And I think for most people with hemophilia, if you talk to them about, obviously there's a lot of monitoring in year one, less monitoring after year one. But if you were to talk to most people with hemophilia and say, look, if you get gene therapy, we'd still like to see you a minimum of once a year, twice a year. I don't think that's going to be a big burden on them. And I think, frankly, most people would welcome that, because
Yeah.
people with hemophilia have grown up used to having their health checked once or twice a year by their comprehensive care centre, and I think they would actually they would do better continuing that.
Hmm.
And so it's better for the individual to have that lifelong follow up, because the other thing, of course, is you can get you do all your monitoring in year one and year two and year three, and then you stop going to the center, and you are assuming that you're going along with the same factor level. What if that factor level has changed? What if your assumption is incorrect? So even if you checked every 6 months or twice a year on an ongoing basis, and checking all the other areas of health as well, the impact of hemophilia on everything else in your life, other health conditions, and also it doesn't just help the individual. We need that kind of information from the first several hundred patients to have a licensed gene therapy, so that we can actually have enough information to really have real world evidence.
Yeah.
And I think anybody with hemophilia who's having a licensed gene therapy, by putting their data make it get doing those visits, doing the monitoring, making that data available to a registry that really are helping to expand the pool of information that's needed to make long-term decisions on this.
Yeah. Yeah, and I think that really what I've seen is that, the hemophilia community is very altruistic. So, it's not only important for someone's own health, but then also, seeing value for the future, gene therapy recipients, future generations.
And of course, you've also got to factor in, of course, situations like a young man gets gene therapy and then decides to move abroad or move somewhere else, and making sure they're not lost to follow up, that they're linked in with the center somewhere else. That can happen. And in fact, I think the availability of gene therapy as an option will make it easier for people with hemophilia to choose different careers, to travel more, perhaps to move to another country for a period of time. But that still means they should be followed up and they should not be lost to follow up.
Yeah. Yeah, I think that will be important part of communication between, the individual and the treatment center, and so, there can be help in terms of facilitating identifying a treatment center wherever they move. Yeah.
What are your views on the other long term monitoring required? So not just factor level.
Yeah. Yeah. So, I mean, I think overall health assessment, particularly in terms of bleeding and bleeding that, requires treatment or is thought to require treatment. We've talked about the liver function testing in detail already. There will be monitoring for factor inhibitors. I think there's going to be, you know, development of inhibitor, hopefully non-existent to minimal, but still, it's a critical, complication of hemophilia treatment. So that will be monitored. And then, joint health, physical health. I think maybe tying back to what physical activities then become possible for people who've had gene therapy, again in collaboration hopefully with physical therapists or trainers. So you can don't just start at 100%, that you have the right training and the right equipment. And then I guess, last thing I'll mention is just is the psychosocial evaluation for, as part of the visits, if social work, psychology is available, to assess, um, to make an assessment. That's going to be critical as well.
Yeah, and I think just on the psychosocial assessment, I think also maybe having some sessions, having some peer groups, having some quantitative discussions, because whatever survey you use, whatever tool you use to measure quality of life, they don't always capture everything. And I think you get a lot of insight from having groups of people getting together and discussing this. We certainly did this some years ago when we switched the entire country from standard to extended half-life factor. We did focus groups of people beforehand, and then we repeated that a year later, and we tried to see what difference uh, they had they had in their quality of life. So I think that kind of group dynamic discussion could be very, very useful. I think also you talked about overall health assessments, including any bleeding, and that's an interesting one because if you look at annual bleed rate, I mean, so what is a bleed? Who decides if it's a
Yeah.
bleed? Is it the patient? Is it the clinician? Is this a bleed or is it pain in my joint that could be arthritic pain and I'm not sure? And I think obviously you know the ideal would be to go into the center, have it assessed, and do an ultrasound, see if there's blood in the
Hmm.
joint. But that's what if you live 6 hours drive from the center. I would really like to see, and I know Milan are working on this, the development of a handheld ultrasound that you could use at home and even link to a phone app, so you could scan the joint, send a picture directly to the center, who could tell you whether or not there is bleeding in the joint. Because the concept of what is a bleed is still something that confuses people. And in fact, I think if you're looking at something like payment models for gene therapy, that's why you really can't use annual bleed rate as an outcome for payment models, because it's something that's it's not that easy. It sounds easy to measure, but the clinician can be wrong, the patient can be
Yeah.
wrong. It could be a bleed, it could be arthritic pain, could be from previous damage.
Yeah.
Um, I talked to somebody recently who had gene therapy, and he was playing tennis regularly afterwards, and he got an injury in his arm, and he had it checked and double checked at the center, and it wasn't a bleed. It was a tennis injury,
Yeah.
which happens to lots of people who get to play tennis, but he just wasn't used to getting normal injuries, which weren't bleeds. I think the other thing in terms of long-term monitoring is it would be good to look at that in terms of helping people to recalibrate their life goals.
Mhm.
So if somebody has had gene therapy and they are looking at their travel, career options, their activities, their sports, I think a periodic discussion once a year, twice a year with the center, just to, I'm thinking of doing this, I'm thinking of doing that, I've started doing this. It's a good discussion to have.
Yeah. No, that's a great point. I think, we talked about that as part of the World Federation of Hemophilia shared decision making tool in
Yeah.
terms of, part of the tool is evaluating the goals and, how the current therapy is working. But I think that's really important to then, as you said, recalibrate, after change in treatment or having gene therapy to see, um, what new goals can be achieved.
Yeah, and certainly we did a fairly large workshop recently in Ireland where we asked people, four questions. What current restrictions do you have on your life because of your hemophilia? What travel or career options would you like to reasonably pursue?
Hmm.
What sports or activities would you like to reasonably pursue? And I say reasonably because you're not talking about boxing or rugby, but reasonably pursue. And then with those three questions in mind, which treatment option do you think might best work for you in that context? So it's really getting people to turn it on its head. And rather than, as we've always done in the past, saying, this is the treatment we're giving you. Now, what do you think you can do with your life? Say, what do you think, what would you like to do with your life that's reasonable and realistic? And then what treatment option might best work to achieve those goals for you? So it's changing a mindset, I think, as well, which would be necessary.
Yeah. And how do you think, that we might, sort of facilitate some of the follow up? I mean, I think typically, the standard is coming into the clinic and having the labs and, exams and discussions. But what do you think? How do you think
I,
we
I,
might decrease that?
I think this needs work. So we've had people with hemophilia, including myself, who took part in clinical trials, and we were fully aware of all the monitoring visits required. And it's quite a commitment, especially in the first year. I mean, when people talk about gene therapy freeing you from the center, I'd never visited the center as much in my life as in the first year after gene therapy. But this was not a surprise. I knew
Right.
this, and I fully accepted that. And that's fine, but I'm the CEO of a hemophilia society, and if I'm going to take time out to go to the center, that's not a problem for me. But if I'm going to college, or if I've got a job and my employer isn't incredibly understanding, and I'm saying to them I need to go in once a week, or I need to go take all this time out, I think we need to start thinking about different solutions for this. Now, first of all, which center? So the gene therapy will probably be given in a major center, the dosing center, but maybe that center is 6 hours drive from your home,
Hmm.
or 3 hours flight. So in that case, the major follow up should probably be done at that dosing center, maybe once a year, twice a year. But the routine follow ups every week, you can't expect somebody to do a 6 hour drive, every week, twice a week. So I think in that situation, you'd have to have an agreement with your local treatment center, your home center, to do the routine bloods and so on. But in that situation, it's absolutely vital that there are no gaps in communication between two centers. They need to
Yeah.
be very, very clear about who is doing what and who is doing which blood tests, who has the responsibility to notify the patient if there's, for example, increased liver enzymes, who is the responsibility for communicating between the centers. And I think the other thing is that make it as easy as possible for the patient to look at the options. So if they're living close to the main center, that's fine. If they're not, if they're a long way away, could you use telehealth for some of the consultations? Could you use the local laboratory at the local hospital or the local laboratory to take some of the bloods? Could you arrange to have calling at the patient's home to take the bloods? Could the centers be flexible in terms of their timing? Does it have do the bloods have to be taken at 9 in the morning? Could they be taken at 7 in the morning or 7 in the evening, so the person can go before or after work or college? So I think flexibility is needed all around here, you know, um, because I think there would certainly be some people who would think I'm interested in gene therapy, but I can't commit to it, not because I'm concerned about the therapy,
Yeah.
but because of my job and my schedule, and I just can't take the time out from that schedule. So I think the centres and everybody involved has a duty to make it something that's reasonably practicable for the person to do, and that means being flexible with timing, with locations for bloods, and with arrangements for taking bloods.
Yeah. Yeah. And I think, we really want to minimize health disparities in terms of access to gene therapy. So everything you're mentioning in terms of, you know, addressing the burden of follow-up is very important. And I see there's a question that came in related to just strategies to maintain communication between patients, caregivers, and healthcare providers during this phase. And so I think it that also may be center dependent, but I think, certainly having the visits, but then also, having the, open for phone calls, and even if there's, the patient electronic portals, being able to send non-urgent message that way, or if, some centers may use email or text, in a secure manner. So I think figuring out what works best, for all the individuals involved should help communication.
I agree, and in fact, you know, certainly during the clinical trials, that there were research teams, research nurses who stayed in constant contact with the patients, very good communication, I say using text, using email, using WhatsApp, and there's no reason why that shouldn't continue to some extent post gene therapy,
Hmm.
post clinical trial with the licensed gene therapies. I think the centres are going to require specific people, specific resources to do that. I think you're not going to have queues of, you know, loads of patients at any given centre having gene therapy at one time. You're talking a relatively small number of people on a perhaps on an ongoing basis. So I think the centres need to have the staff and resources to be able to maintain that contact regularly with the patients, because it's important in terms of outcomes. It's important in terms of promoting and helping with adherence to the protocol. And frankly, it's also important in terms of gathering information for the next group of patients coming down the line in relation to what may or may not be happening. So I think those communication strategies also depend on resources. So it's not just providing the gene therapy; it's providing resources for the centre to be able to properly follow up and manage the patients.
Yeah. And I know, at least in US, but I imagine, throughout the world, there is concern about, sustainability of the treatment centers with, changes in treatment. And so, it's going to be really important for the centers to figure out how to maintain, their clinical staff and resources for the community. And of course, at the treatment centers, we see, there'll be many more patients who aren't having gene therapy, that have
Yeah.
milder bleeding disorders or different bleeding disorders that, aren't amenable to gene therapy at this point. But I think, um, it's something that at the treatment centers we're thinking about it on a regular basis.
Sure, but it's not just gene therapy. I mean, if you look at, you know, the mimetics, the further mimetics coming down the
Yeah.
line, rebalancing agents, the new very long half-life factor 8, all the EHL factor 8s and factor 9s. There is an enormous number of therapeutic options now for hemophilia, and a
Hmm.
lot of choices to be made, a lot of discussions to be had. So it's a more complex environment, and
Yeah.
that complex environment needs healthcare staff who can engage with patients and discuss this. So I think it's absolutely crucial that the centres have the staff to be able to do that discussion.
Yeah. Yeah, because I think in many ways we actually need more, more clinical staff and resources for that education, for this, the monitoring, and, being able to respond immediately to the adverse, liver tests, and that we talked about, and management of the immunosuppressants.
I agree, and you want to do everything possible to promote adherence to the protocol, to make sure that the if there is there a barrier to the patient being able to do the visits, being able to adhere to the protocol, identify that barrier earlier, early, deal with it, and then make sure that adherence continues. Because it's what you don't want to see are people getting gene therapy and not being able to adhere to the protocol and then getting poor outcomes.
Yeah. And I mean, unfortunately, this is minority of people who get gene therapy, but some may not respond or may lose response
Yeah.
over time. So they're going to be able to need the support of the treatment centers to be able to go back on to prior treatment or something similar so that they can continue to prevent and manage bleeding.
I agree. I mean, the good thing is, of course, that having gene therapy, even if it doesn't succeed for you, does not cut off your previous therapeutic options. But you're absolutely right. After a period of time, people may have to go back on their previous or another therapeutic option, and that means not losing the skill to self-infuse, keeping in touch with the center. You don't want to go off, have gene therapy, disappear entirely from the center for several years, and then realize you've got to go back into the system. You need to maintain that contact.
Yeah. Yeah. And so we talked a lot about the monitoring, and maybe we can switch focus a little bit just in terms of the collection of that long-term monitoring data as part of registries.
Mhm.
And I think particularly starting with the World Federation of Hemophilia Gene Therapy Registry is now live, um, and collecting long-term safety and efficacy information about gene therapies for hemophilia. And this will really allow the collection of these rare events that may occur in a small number of people across the world. And given the fact that we certainly talked about what we know in terms of potential outcomes, but there may be unknowns that could be picked up through the registries. Do you have strategies, I guess, in um, that you're familiar with, just in terms of encouraging enrollment in the WFH registry?
Well, I think, first of all, pointing out what's the rationale for having a global gene therapy
Yeah.
registry. It's a rare condition, and it's going to be a rare therapy in a rare condition, which means there won't be enormous numbers of people on gene therapy in any, and there certainly in any given country there won't be. So, if you want to start looking, as you say, at trends, at patterns, at outcomes, if you want to start looking at are there any rare adverse events that we haven't seen, you can't do a registry for Ireland or for Germany or for one
Mhm.
country and decide, oh, we'll just look at that data. That's a very, very small data set. You need to accumulate all the data together to have enough data to answer the questions. So I think it's in the patient's best interest to be enrolled in a gene therapy registry globally. It's in the centre's best interest and the clinician's best interest. Now, sometimes I think the barrier you might see is saying, well, we already have a national register, we're going to do our own, we're going to register it locally. But you know what? The one doesn't exclude the other. So I think, WFH have a strategy to include to link in with existing national registries. So if you're in a country, and for example, I know in the USA you've got Athens. In
Mhm.
in, in other countries, I think Germany will have a national registry. By all means, put the data into your national registry, but then make sure that that data, anonymized, can also go into the global registry. I remember many years ago at an EMA meeting, and they were talking about inhibitors, and they were bemoaning the fact that there was no global registry on inhibitors,
Mhm.
no global database, which may have answered a lot of the questions, and that was never achieved. We have to do that for gene therapy. If we don't have a global registry, we'll have small pockets of information around the world, which won't answer any of the questions that need to be answered. But I think it must be painless, it must be seamless, and I think by either individual data going into the registry or country registries linking with it on an anonymized basis, um, that would be useful. And also, it should give the countries then will get back reports on how their
Mhm.
data compares to globally. So it's very, very useful, um, because even if you look at the analogy of the WH annual global survey, we send in our data every year, but it's very, very interesting then to look at our data compared to other countries in the region and globally. So I think it'll be very, very important to have it in the global registry. That's the only way we're going to be able to really assess long-term safety and efficacy.
Yeah. Yeah, no, I agree, and yeah, it made me think of you sort of get at maybe a dashboard that populates over time, where you can see your country or even center, and then how it compares to the full data set. And you did mention in the US that Athens will have the registry, which is through Athens Transcends, and specific gene therapy outcomes. So, at this point, Athens trying to get all the US treatment centers on board in terms of having that registry available, and that data will feed into the WFH registry.
Yeah, and I think the WFH registry had input and collaboration from ISTH, from other organisations, from EHC, from EAD, and I think it's just EMA have just endorsed it as well. So I think what we don't want to see are a lot of different registries. A lot of different registries are fine, but you have to have one global registry which collects the data together. Otherwise, we simply won't be able to answer the
Yeah.
questions in the medium to long term. And I think in terms it brings on to patient support networks, and so we talked at the on last podcast about coming up to gene therapy and that decision, and I think the patient support networks have a major role to play in terms of promoting information, knowledge, education regarding gene therapy. Um, there are a lot of misconceptions about gene therapy out
Mhm.
there. So people need to know what it is, what it is not. And I think in any given patient population, so now that we have licensed gene therapies, and this is something people can think about if it's reimbursed in a country, we have an entirely heterogeneous patient population in any country. You have people who have PhDs, and you have people who didn't finish high school. You have
Mhm.
people with a lot of interest in science and people with no interest in the science. So, but yet you have to give them all access to the knowledge and education and information they need. So I think, and also if the centres are starting to do an informed decision making, shared decision making process with patients, and you're starting a dialogue with a patient who comes into you and he's thinking about gene therapy, or you want to discuss gene therapy with him. I think one of the roles of the patient organization is to bring the person to the point where they're ready to start having that discussion with the clinician, giving them the basic information. So, what is gene therapy? How does it work? And talking through all of these areas. And certainly in Ireland, we're looking at 7 stages of education, basic information, eligibility, which you cover early on because there's no
Yep.
point in bringing somebody too far down the road with that journey if they're not eligible. And then the comparing it to the different treatment options they have in their country, which is crucial, and then looking at the decision if they're making a decision, and at that point using teach back to make sure they've understood what was said to them previously, and then talking about the dosing, what that involves, talking about the follow up in the first year, and then talking about long term follow up. And these would all be different stages. And also, I think with that different patient population, you have to give them the information in a medium they consume. So booklets, certainly information on the website, but also social media, infographics, videos, podcasts, uh, events like this. I think can all add to the educational content. The Canadian Hemophilia Society are doing a series of 8 podcasts.
Mm.
The European Hemophilia Consortium have an app called EHC UK, which has quite a lot of content on gene therapy. EHC also produced a very detailed guidebook on gene therapy, which I would not expect the average patient to read, but this is a resource that patient organizations can take from to produce their own materials. Um, NHF and the World Federation of Hemophilia are producing various materials. As you said, the WH have produced a very nice shared decision making tool, which we've already tried out, and I think it's excellent. Um, and the Canadian Society, others are producing their own materials. And in fact, we've just got one of the companies have agreed to support a clearinghouse where there will be a publication with links to all of the patient information out there from all of the major countries and a lot of the other information as well. So it should not be that daunting for a patient organization if they're thinking about we need to start educating our members about gene therapy. They need to start from scratch. They can copy and
Yeah.
paste directly from the website to a certain extent. They can do a horizon scan for what's out there and use some of those. And I think we do that all the time in patient organizations. We try not to reinvent the wheel. So if I want to do a new booklet on mild hemophilia, I look at the NHF, the CHS, the WH, EHC, see what they have, and if there's information already there that we can change and we can use, then we will do that. I think it'll be exactly the same with gene therapy. I think we don't need to reinvent the wheel. Various patient organizations are taking various initiatives, and so we can work with each other and help each other. And none of us are precious about the work. We all share what tools we have. And of course, the other thing that's hugely influential, Courtney, is geography. It's very easy for me to do gene therapy education in a country like Ireland. It's a small country, and I'm planning, a series of meetings with patients as well as information materials and and websites and so on. But we can actually do small meetings with groups of people and have personal interaction with them. That becomes much more difficult in the USA or Canada or Germany or larger countries purely because of geography. So their strategies for that have to be slightly different.
Yeah. I guess the Zoom and webinars help that a little bit, but it is nice to really be able to have, these some discussions in person. And there's another question asking to provide examples of successful shared decision making experiences from practice, particularly in cases where patients had initially hesitated about gene therapy. And I'm a pediatrician, so see mainly children and adolescents up to 21. Have had started now having the discussions about gene therapy even in the younger adolescents and sharing the tool. So I think in terms of like the implementation of the tool, even my practice is early on. I've had probably more experience just in terms of this with some of the other um, therapies like the factor 8 mimetics or extended half-life products, and had a particular experience a number of years ago with a teen with severe hemophilia A and inhibitor who was really on maximal bypassing therapy and still having poor outcomes, lots of bleeding, hospitalizations, dependent on external central line. And so I, started talking to him about the factor 8 mimetic. And, he came in with a lot of misconceptions that, I'm not exactly sure where he got. But when we really started talking about his goals and, and as well as trying to, address the misconceptions and get the right information. What it was that he did not want his central line anymore because he wanted to be able to swim in the ocean. And so I think really the central part is the goal setting that we've talked a lot about. But I know, Brian, you said you've used the tool in some of these groups in Ireland. I was really fascinated about that
Yeah,
as the
yeah,
option.
we used the WHSTM tool at a conference last month, and just brought people through it to see what their reaction was, and they liked it. And I had somebody there simulating a decision, so I had somebody pretending that they were going to they were looking at various treatment options, and then they went through the tool and we asked them questions. But I think it's something we would then use in small groups and we'd use with individuals. And I mean, the question about shared decision making and real life experience with gene therapy isn't there yet because there have only been, 5 patients treated globally with a licensed gene therapy. But we've seen it, as you have, Courtney, with previous therapies. So I'll give you an example. When the factor 8 mimetic was made available in Ireland a couple of years ago as a treatment option for any adult or child with severe hemophilia or moderate hemophilia A, we organised meetings in 3 of the cities, and we invited people along, and we had clinician there, and we had information about the product, and we had samples of the subcutaneous needle and the kit, and we talked to them about that. We also produced two booklets ourselves on this, information booklets, so people were able to look at the kit, they were able to ask questions, and in that group setting, in that dynamic group setting, with 20 people in the room at a time, somebody asks a question that you hadn't thought of, and so you leave the meeting with a lot more information, and that really was then they were they were more ready to go into the clinician and have that individual discussion for themselves or their child. So I see us doing the same with gene therapy, getting people to a point where they're ready for that individual discussion with the clinician. And it's going to be more complex in gene therapy, but the same principles apply. You know, what is the therapy, what it is not, why do you want this therapy? Um, how does it compare with your other treatment options? In fact, another workshop we did was quite interesting, as we talked to people about the four major groups of therapies: factors including extended half-life factors, the mimetics, the rebalancing agents, and gene therapy. And we asked them to think about which of those four they were interested in, and then why. What was their, why were they interested in that? So yeah, having those discussions as a community in small groups really get people ready for the concept of it's a bit like running a 10K race. You don't go in cold. You do some stretching, you do some warm-ups, you do some shorter runs earlier. It's getting people mentally ready to start that whole discussion about therapeutic options. Whereas in the past, many of them may well have been, well, the doctor says this is the treatment I should be getting, so I'm fine with that. You can't do that with gene therapy.
Yeah. No, and one of the questions I've gotten before is that, for patients that then, may have, this participate in those events and they prepare themselves, and then how do they then come into the treatment center? And I think I'd like to think that all the treatment centers know about the tools and are now becoming well versed in gene therapy, but is there a way sort of to even prepare the patient to bring this up to the clinical team?
Well, I think the discussion about just be methodical. So the centre have to be familiar with a shared decision-making tool. So does the patient, and this should be. I mean, this is not a 5-minute conversation at the end of a clinical appointment. If
Yeah.
you want to discuss gene therapy, it's at least 1 hour, and it's not a one-off conversation. It's several conversations. So I think these need to be structured and scheduled meetings.
Yeah. um So I'm just looking at another question coming in. Yeah,
People
so
who have
this,
lost transgene expression, yeah. I
yeah,
mean, there are no shared decision-making tools, but in terms of strategies, um, I think they have to be aware from the start that, first of all, they may not get any expression. And secondly, if they get expression, they may lose it after a period of time. However, they can go back to their previous therapy. But certainly, it is something that people need to be aware of as a possibility, and prepare them for that. And obviously, it will be disappointing. Um, but I think they need to be aware of that possibility before they start.
yeah. Yeah, I think it's part of the initial discussion, and it actually brings up, the point that we wanted to talk about is in terms of, sort of future clinical trial eligibility. So, yes, it could be either for someone who has considered all the options, has learned about gene therapy, isn't quite ready, and then but so you need to think about, okay, well, what's the next generation going to look like? But then also eligibility for someone who's had gene therapy but's lost expression. And with the current AAV based therapies with gene addition, then patients will not be able to be redosed because of the immune response that even goes across different AAV vectors. But there's other strategies for gene therapy, like gene editing, more cellular based therapies that might be an option.
I agree. I mean that there are other, lipid nanoparticle or delivery systems in the future might be an option, but at the moment you're absolutely right. If somebody gets a gene therapy and they don't get expression or they lose expression, they can't have another gene therapy. And even if it was possible to have another or a different AAV gene therapy, I'm not sure a health system would pay for it twice for the same patient. So that's something else we need to consider. So it is a one-off therapy, and I think that needs to be borne into to account when people are making a decision. There's a question about, does the SDM tool help individuals understand their eligibility criteria? It does to some extent, yes. No, it doesn't go into huge detail, but it's more about, I look at it as more about uh, getting you thinking in a certain way about what you want from your life, what you want from your treatment, how you marry those two together. So it certainly does cover that. It's a very, very good starting point for the series of discussions between the clinician and the patient.
Yeah. Yeah, and it's yeah, the you can basically choose what you want to learn about and go through the different aspects of
Yeah.
each treatment.
And
So
I think just in terms of sort of other issues or remaining questions, in terms of unmet need, we've had discussion about can females with severe hemophilia get gene therapy? What about children? Well, obviously, at the moment, children can't, although they are starting clinical trials, I think from age 15 to 18. It may theoretically, I think, be possible for people aged 12 and older eventually to get access to gene therapy, but I find it difficult to see anybody under 12. What do you think, Courtney?
no, I agree with the current again with sort of the AAV based therapies that really depend on the liver and because of immaturity of the liver in the younger ages just isn't anticipated to be efficacious. But again, maybe others I think there are emerging other therapies that could be um, potentially efficacious in the younger age group. So, I mean, we're in a really exciting time in medicine and particularly in hemophilia with a range of very effective therapies and being able to have the choice to see what you know um, matches the goals and the treatment preferences and having excellent outcomes across the board.
And I think in terms of females with severe hemophilia, there were no females in the clinical trials, but looking, depending on the wording of the licensing, they may not be excluded. I know that the license for in Europe for the hemophilia B gene therapy talks about adults. It doesn't talk about men with severe hemophilia. It talks about adults. So if we can stay away from identifying one gender or the other, then I think anybody with severe hemophilia may well be eligible.
Yeah. Again, it's it mentioned equity and being able to have effective treatments for as much of the population as possible is really critical. And I think then it brings back the point of having the registry, so we really then can have more diverse population where we're getting uh, outcome data.
And of course, there are ongoing questions about long-term safety, the theoretical risk of potentially developing insertional mutagenesis or cancer. There have been 4 cases of cancer in people who've had hemophilia gene therapy, although all 4 cases were found to be unrelated to the gene therapy. And of course, we must remember that people with hemophilia will develop cancer at the same rate as anybody else in the population. So you need to make sure that you can separate those. Um, and the second thing is, long-term durability. How long will the gene therapy last? The simple answer is we don't know. We don't know. Um, it currently looks as if the durability of the hemophilia gene therapy will be longer than the but we just don't know how long it will last.
Yeah. Yeah, and I think many questions to continue to improve the therapies as well as management of the liver effects, optimal sort of uh, um, regimens for management of that. So still lots of work to be done. Um,
But certainly, dialogue, communication, information, collaboration between the patient organizations and clinicians are really key to getting good outcomes here.
yeah, agree. So, well, it's been a great hour talking with you, Brian, and it's been great to have questions from the audience. And so, like to thank you all for being here today, and remind you that there is wealth of educational resources through the ISTH Gene Therapy Initiative. You can access this recording as well as the part one there, as well as other webinars and resources. So thank you very much and hope everyone has a great day.
Thank you. Bye bye.